Before today's episode, I want to ask for your interest. We'd like to open our Keep It Real episodes up to you, the listener, and have discussions on topics driven by the content of this podcast and our social media. If you're interested, we'd love to hear so by dropping us a message on our Instagram. Our handle is ResilientPPT, ResilientPPT. Thanks.
Welcome to the Resilient Performance Podcast. This is Keep It Real number 10. So we're going to dive into surgeries in general, kind of talk about anything related to rehab, getting back to training, and specifically with our partner Doug here, a week out of some minor back procedure, but definitely doesn't feel minor early on. So we'll dive into that, how he's doing, and kind of just the process of it, and what he's able to do physically now, and what his plans are going forward, and what we can do to help him as therapists. So Doug, you want to just sort of intro the background to, it's almost like a little case study we'll do essentially, and just kind of fill people in, and then we'll just talk generally about surgeries after that.
Yeah, so I'm like a week status post laminotomy at L4, L5, L5, S1, and then foraminotomy at both those levels. And just like to kind of preface, like I'm usually more private about this stuff because, it's like the world doesn't necessarily care that I had surgery, and like I haven't really had much hardship in my life. So a lot of times on social media, people make it like, oh, like, I'm going through all this adversity and like I'm going to show you how I'm overcoming it. Like that's not really the point of this. Like I'd frankly almost rather not talk about it, but I think there's value from like a clinical standpoint, because I learn a lot just clinically, when you're on the receiving end of care versus the one doing the care. And then even like systemically in terms of healthcare. So like, I guess a little bit of the history on it was for as long as I can remember, even since I was like 20 years old, I just always had issues with the left side of my back, like left buttock region. And then when I was in the military in jump school, I ended up breaking some ribs, but before they came to that conclusion, I had to get various kinds of imaging to see what was going on. And they told me at that point that I had congenital lumbar stenosis. At the time, I'm like 23 years old, so I didn't like really think anything of it. But I remember them saying that my spinal canal, in the lumbar spine was about like 40% of the width of normal. And they attributed that being congenital. I mean, I was doing some training at that point, and I had done even some heavy lifting, but maybe for like 3 years. Like in 3 years, you don't get 40% of the width of a spinal canal. And I even have history of it in my family. Like I remember my father talking about having stenosis, and my grandfather, even though they ended up not needing to have surgery for it. But that would always be an issue. Like when I would train and have a problem, like it would be that, whether it was like through like heavy deadlifting or squatting, if I kind of like pushed it too far, or, carrying a pack over, many, many miles, like that would just always be the part that like would feel stiff. And sometimes like no matter how much I would try to like stretch it, mobilize it, get soft tissue work, like it would always feel tight. And it kind of makes sense now, knowing what I know, that there was probably some nerve root compression even then. And as we know as therapists, you can't really like stretch your way through neurological tone or tightness. But so I dealt with that until like 2 years ago. Like it really wasn't a problem. Like it was something that like I might like quote unquote tweak my back and then be, have to work around it for a week, but then I would be fine. But basically right around 2 years ago, like around Thanksgiving time, in the weeks leading up to that, I had progressively worsening buttock pain to the point that, and you guys might remember because we had our like Christmas party early that year in like November, like we were just walking and I would have to like stop every like minute or two to like sit down. And it was at the point where like, I remember, we were working at Solace at the time. I would take the train subway to Penn Station, and I had to walk the 4 or 5 blocks east to Solace where we were practicing. And like, I remember that like at one point, like, oh, like this is a pretty difficult walk. Like, I feel like when I get to Solace, I have to like sit down. And then it would get to the point where like, I had to do half the walk and sit down. And then it got to the point where I couldn't really walk that much at all. And I was taking Ubers to work, which is kind of weird because before I was getting this buttock pain, like I remember doing some tempo running at the field, and just to test myself, I'm like, I'm going to do a 400 and see if I could break 60 seconds. And, I broke 60 seconds, which is not like a major athletic feat, but at 38 years old, it's okay. And it speaks to the fact that like, I'm running a sub 60 400, and then like 4 weeks later, I'm taking Ubers to work because I literally can't walk more than a block. So I ended up at the time, didn't have any health care except for the VA, went to the VA, told them what was going on. And they said that they were going to get me an MRI. This was on a Thursday. They were going to get me an MRI for the following Monday. So we're on Thursday now. That Saturday, 2 days later, I collapsed in the shower and like literally I had to crawl out of the shower like into bed, and I was like laying on the side of the bed. I could barely move. My wife had to like hold a bottle while I peed into it because I didn't want to get up and go to the bathroom. So I'm like, all right, this is pretty bad. But because I didn't have health insurance, I didn't want to call an ambulance. So I ended up somehow like hours later just like hopping on one leg down the stairs, got in a cab, went to the ER there. And that's where, some of the, you just see the disparity in care throughout different systems and providers. Because I think because I was like young and healthy when I went there, they were a little bit dismissive of the fact that like, yeah, I mean, I was like able to walk kind of gingerly, and I didn't have motor weakness in the sense of like foot drop, or I didn't have like cauda equina. It's like, oh, like here's a guy who's like limping in. But the ER doc, when I told him, what I'm normally capable of doing, and that how like I hadn't been able to walk more than a block over the last couple of weeks, he took it very seriously and like he wanted to actually send me to NYU to get an MRI right away. But because it was the weekend, you basically had to have like really, really serious, almost like life and death situation to get an MRI there on the weekend. The neurosurgery resident, in my opinion, was like a little bit green, and he was kind of like, oh, it's just sciatica. The ER doc was kind of advocating for me, trying to get more, and finally he was able to at least get me a CT scan, which showed, that's not like the definitive thing. Like I needed an MRI, but the CT scan indicated there might have been a cyst that was pressing on a nerve at S1, which explains some of the neurological symptoms. But ultimately, like I needed to get an MRI. They told me to go in on the following 2 days later on a Monday to see a specialist at the VA to kind of like get the remainder of the care that I needed. And it turned out that when I went to the ER on that Saturday, I didn't have an MRI scheduled for the following Monday. I had a neurological consult. So I was under the impression that when I was at the ER that I was going to get an MRI 2 days later. It was not an MRI. It was like, it was a consult to possibly get an MRI down the road. So there's a little bit of dysfunction there. So I showed up at the VA the following Monday, 2 days after the ER. And again, they kind of like were a little bit dismissive. They just wanted to give me like some pain medication. They're like, oh, it's just sciatica. I was like, and from being in the field, I'm like, can I at least get an MRI to see like where this is coming from? Like, it's not normal for somebody at my functional capability to not be able to walk more than a block and be in this amount of pain, where I was like literally helpless. And so they were like, well, we can't get you an MRI for 6 weeks. So that was when I was like, all right, like I'm done with them. Luckily, through the connections that we have as healthcare providers, and from my connections in the military, I called a physician friend that like is able to get things done. He got me an MRI literally that day. I went to Long Island that Monday afternoon after going to the VA. I paid out of pocket for the MRI, and I'm luckily like I'm able to do that. But I wasn't going to wait 6 weeks for the MRI because I'm like, I need to know what's going on, because like we get paid by the hour and we run our own business. Like if I can't physically work, then like business shuts down. And on top of that, just for like, I wanted to get out of pain and get definitive treatment. And in my mind, I knew that I probably needed to get like an injection of some kind. So I got the MRI, and the MRI showed that there was the stenosis. It showed some discal changes and some nerve root compression, but there was like a lot of stuff going on. And it was hard to tell if it was the disc or the stenosis or the cyst. But at that point I was able to at least, start getting on track to see a specialist. And the funny thing is, after I got my MRI that I paid out of pocket for, the VA called me and they were like, oh, we heard that you were in the ER a couple of days ago. Do you want to like make an appointment to see like a pain management specialist, which I think that's who would do the injection in the VA healthcare system. So I'm like, yeah, like I think I need an injection. I actually have an MRI now that I got privately, so maybe I can show this specialist at the VA the MRI, and then I can get on the fast track to an injection. And this is November, mind you, and they were like, well, his next available appointment's in March. And I'm kind of like, how do you say that with a straight face? Like, you expect me to wait, December, January, February, 4 months to like actually get like a definitive treatment for this. So that's when I was like, all right, like I am done with the VA system completely. And again, I will say that there were some good people there that when I went, like especially the ER doctor was, I think, very responsive and took my case very seriously. But when you work in a dysfunctional system, even if you have some good people, it doesn't matter. So I think there's some, and this is a separate discussion that I want to have separate episode on like healthcare. Like I think there's ways to, get people access to healthcare, even people who can't normally afford it. But whether or not the government is the best vehicle to provide that, I think it could be, but I think it's a discussion that has to be had. I don't think it's clear because sometimes people who support, like government sponsored healthcare for everybody or like tout the VA as a success story. For me, I would say it couldn't have been more disastrous. So I ended up getting on my, like maybe like a month or two later when I could, getting on my wife's health insurance, which again, I'm lucky that she had a job that had good health insurance so that I could do that. But then I went to a physiatrist that we know and trust and collaborate with on patients. And like he was, outside of that ER doctor, like the first like competent person that I really dealt with that was like, look, you've got some nerve root compression here. Like there's some structural things going on that like, we can't really change, but we can try to reduce the inflammation around the nerve. And so I ended up getting a series of injections, which like I thought like helped. And it got me back to being more functional. Like this happened in November when I went to the ER. In around New Year's, I was actually skiing, which I wasn't 100%. And I still had some paresthesia, maybe a little bit of motor weakness, not really like any back pain. And that was the weird thing is like, when this was really bad, the pain was more of like a burning, electric type pain down my leg. Never was it back pain. But the injections allowed me to be more functional. Like I was able to train and work around the problem. I wasn't doing anything, more like single leg stuff, core stuff, some like low level aerobic stuff. And then over the course of like the next couple of months, I was really at the point where I would say by maybe like March or April, I could almost do whatever I wanted to do, but I didn't have that like 90% gear. Like when I would like play tennis and I'm like a college level, like for people who know UST, like a 5.0 level player, like I could hit with a good player of my level when we're cooperative, but like if we played a match, I didn't have that 90% gear where like if somebody hit a short ball or a ball in the corner, like I knew that I had the capability to run and get it, but like there was just an inhibition there where I didn't want to do it. But again, I'm like, if for the rest of my life, I don't have that 90% gear, I can still do mainly what I want. I was skiing, kite surfing, doing martial arts, and even doing martial arts, like when I would grapple, as long as the grappling was mainly cooperative, like again, I couldn't in an awkward position, like torque somebody and like really, really like try to execute a throw or a hold. But if it was like at 80%, I felt good. And then I'm like, well, I'm not a professional fighter. So again, I was willing to accept that like with the stenosis that I had and the nerve root compression that might never come back. But then fast forward to like maybe 2 months ago, right before my son was born, I started to get that thing where I would walk and felt like I had to sit down. And that it came on like really quick out of nowhere because again, I was very, very functional. I was sprinting at max velocity, training lower body really hard. And then 2 weeks later, I'm like, wow, like I can sprint, but I can't like stand up for that long or I can't walk for that long. And then when my son was born, I got to the point where like I couldn't stand up and soothe him for more than a couple of minutes without having to sit down. So I'm like, all right, like this is affecting like my life now, my ability to care for somebody else. So my wife and my son were in the hospital for a couple of days after the birth. I actually went to the physiatrist that we know in the middle of that to get an injection and try to buy myself some relief, which speaks to like how serious it was, because I wouldn't normally leave my wife and my son in that situation. I wanted to spend time with them. And I think that bought me, again, a little bit of relief. But then a couple of weeks after that, it just got to the point where I really couldn't tolerate standing or sitting very long, got another MRI. And at this point, I'm thinking like I probably, if the stenosis is bad enough, I'm going to have to remove that fix that mechanical problem. So there's compression on the nerve, like no matter how many injections you get and you try to work on function and mobility, like there's a mechanical problem. So I started to think like, all right, I'm probably a candidate. Got a newer MRI, hadn't really changed that much from the last one. And that's when I ended up getting 3 consults, one with a surgeon that I've collaborated with on patients. And he was kind of the one that like, I knew that if I was going to have surgery, I wanted to have it with. And then I had 2 remote ones with people in different parts of the country, just because I wanted to just make sure that like all 3 of them said, look, you are like a legitimate candidate for surgery. And it wasn't going to be a case where one of them was like, yeah, you need surgery. And the other 2 were like, no, this is, conservative treatment. But I explained to them that I try conservative treatment, that I am a PT and kind of aware of what I can and can't do with this. And unanimously, they all said that I was a candidate for surgery because there was just so much at L4, L5, so much central stenosis, and at L5S1, so much foraminal stenosis, the nerve just couldn't breathe. They didn't say to get surgery right now. They're kind of like, well, you'll know when you need surgery. And that, once all 3 of them said that I was a candidate, I'm kind of like, well, I feel like I'm at that point now. Like I can't really do normal, quote unquote, normal things. Like forget about skiing and all the fun things I like to do. Like I couldn't walk to work. And even, at that point, I was treating patients, but I was taking Ubers or cabs because I didn't want to walk, like even from the subway a couple of blocks to get here. And it's not that long a walk. But the interesting part with that, and again, this is where medicine, if you're not, and even backtracking, like if you're not in the field, it can be very hard to navigate all the specialists and people you need to see. Like luckily, I had expertise and relationships that I knew like what needed to get done, so I could orchestrate it myself. But I don't know how quickly I would have gotten resolution even 2 years ago to get the injections if I didn't know what I needed and I had to go from specialist to specialist, because no one really tends to take ownership of cases. It's kind of like, well, I did my part, go see this person, and then it's kind of like kick the can. Fortunately, I was able to like manage all these people and like orchestrate it. And that's where I think that like PT can actually be or physio can be the profession that does the orchestrating, because I think that in a lot of ways, because we're not the ones doing changing the anatomy surgically, we can almost have a bigger picture idea of what's going on. I mean, I think that we're more than qualified to know when somebody needs surgery, even though we can't do it, but we also appreciate the functional piece. So I think that like where PTs can, I think like distinguish themselves from other healthcare providers is to be that case manager. And then, like I work with somebody just now, like ironically enough, where she could potentially be a candidate for surgery or at a minimum an epidural because she had some nerve root compression and motor weakness. And like, I literally did not treat her during the appointment or do much of an assessment. I looked over her MRI report and I set up an appointment with the spine surgeon tomorrow and the physiatrist the next day. So it's like, look, go see the spine surgeon. He's very conservative. You have motor weakness. If you need surgery, I think he's a trustworthy person to determine that, because he's very conservative. And in fact, he wrote a book convincing people to not get spine surgery. So I'm like, if he looks at your MRI and says right away, based on your subjective and your imaging findings, you need surgery, you probably need it. If he says that you don't, then the next day you've got an epidural booked with someone that we all know, and then you'll be on your road to, either way, you'll know what needs to be done. But like I did that for her. Like while she was there, I called these people, and I felt like at that point in time, that was the best way that I could help her. Like, yes, I probably could have had her do some nerve glides and some like help her desensitize the nerve, but like that's not going to do as much as removing that mechanical constriction, because she had stenosis as well around the nerve, or getting some kind of anti-inflammatory to reduce that inflammatory response. So then when it came to these surgeons, they all said that the stenosis was the problem, and they all said that the disc wasn't the problem. They said, yes, like you, like everybody else, has a disc bulge, but the disc is not what's putting pressure on the nerve. It's the central and the foraminal stenosis at those different levels. But what was interesting is they all wanted to do a slightly different procedure. One wanted to do, and to be fair to the ones that did the remote consults, they didn't really have the best view of my MRI. They had to go to like a portal that had pictures of the images, but they didn't have the disc to really like maneuver around and focus in on what they wanted. But one surgeon wanted to do a full-on laminectomy at L4, L5, L5S1 on both levels, on both sides, even though I don't have any symptoms on my right side. So even remove the spinous process and basically just remove the roof on both sides at both levels, L4, L5, and L5S1. The other one wanted to just do a laminotomy at L4, L5, which is basically a partial laminectomy. So just drill enough of a hole in the lamina at both levels on the left side to create some room for the nerve to breathe. Didn't mention anything really about the foramen, although again, that could have been because he didn't have like really great view of the images. And the person I ended up getting the surgery from wanted to do a laminotomy at L4, L5, and then a foraminotomy at both those levels as well. So again, if you're a patient, you're kind of like, how do I know who to trust? I went with the local person, number one, because he was local. I had a personal relationship, but what was really put me at ease too was that I saw him in person, and he spent an hour with me going over the MRI and frame by frame. And he's like, look, I'm not telling you to get surgery right now, but you are a candidate because here is the problem. Like, here is your foramen at S1. You could see on the right side, there's space for the nerve, and on the left side, there's no space. It's completely constricted. But having him go through that in person was just much more comforting than doing it remotely. And that's not a criticism of the other providers, because I knew going in, I wasn't looking to have them do the surgery. I just wanted an opinion. But what was funny was the one surgeon who wanted to do the remote one, who wanted to do the laminotomy at L4, L5, and L5S1, I never actually even talked to him like through Zoom or any other platform. He was just like, I emailed the office because they said they had remote consults. And this is a person that has a practice that has an amazing reputation in the pro sports world. I contacted them about a virtual consult, thinking that like they were going to ask for my insurance and all that stuff. And like I was going to set up an appointment to actually like talk to one of their physicians. They didn't ask for any of that. I was willing to pay. They basically just said, give us a 1-paragraph summary of your history, and then access to your MRI if you have it. I did that, and then I got contacted by one of their surgeons, and their surgeon was like, yeah, you've got stenosis. I would recommend getting like a laminotomy at L4, L5, and L5S1. And like, that was it. There was no like, yeah, but I actually like want to talk to you and explain what's going on. It was kind of like, yeah, just here's an email, take my word for it. Like, either get surgery or don't. Like, it's almost like we're so busy that we don't really care if you talk to us or not. Like, they didn't seem interested in the human exchange of it. And I was perfectly willing, again, to pay for that time to like talk to someone and have it explained to me, because on a rational level as a clinician, like, yes, I know that I'm a candidate for surgery. That's why I'm reaching out after 2 years of trying to manage what I had conservatively. But it still would have been comforting as a human and as a patient, because you don't always want to wear the clinician hat as a patient, to like just talk to somebody and be like, here's why I want to do surgery, and here's why other things didn't work. And like, even going through the MRI, like the person that I saw in New York did, he actually spent so much time with me in New York. He spent an hour where I had to cut him off because I'm like, I've got to get back to work. So there is something to be said for, like you can even make the right quote unquote clinical decision, but like that human element of just saying like, look, I'm going to take total ownership over this. Here's what's going on. Here's the plan. And doing that in person, I think frankly just works better than a remote platform. So, I think that virtual consults can work well for some things, but like, I don't necessarily know if I would want to make the decision to get surgery purely over a remote consults. But it was interesting, again, is like, these are all very well-renowned surgeons. They all wanted to do a slightly different procedure. And I think that they might have all quote unquote worked, but what differentiated, who I wanted to go with was more of the human element. And I just thought that he was more thorough because he spent more time and he literally showed me where the problem was. So it's not that the other people weren't capable of identifying where the problem was, but being shown on the MRI, like, here's where the compression is, here's mechanically what needs to be fixed to do that. So I ended up getting that surgery a week ago today with the doctor here in New York. And, again, some of the lessons learned, I mean, even with something like an MRI, like in our field, MRIs get a bad rap almost. It's kind of like, oh, well, MRIs lead to overtreatment and they lead to, catastrophic thoughts and these kind of things. But I look at an MRI as like, an MRI is an absolute miracle, because without that MRI, now you've got to do a much more invasive surgery to get to the root of the problem. An MRI at least allows you to identify like where the problem is. So now you can do a more minimally invasive procedure. So I think it's a miraculous tool, and I'm sure that like most good physios don't mean to demonize it, but sometimes the narrative on social media because physios want to make it like, oh, we're good and surgeons are bad. Like, I am very grateful that there are MRIs, and I think MRIs are an amazing tool. And if they're used improperly, it's not the fault of the MRI, it's the fault of the provider that misinterpreted it or that used it for the wrong purpose. But like, I think we should all be very grateful for MRIs, and I hope we get to a point where MRIs are cheaper and more accessible, because in an ideal world, to me, if an MRI would cost, let's say like $5, everyone should get an MRI because it's a piece of information. And as long as you're not a moron and you don't misinterpret the MRI, and if someone has back pain and they have no radicular symptoms, no motor weakness, but they have a disc bulge on the MRI, like as long as you as the clinician doesn't say like you need to have back surgery or an injection, the MRI is great. Like it's going to rule out the worst case scenario, and it's a piece of information that basically allows you to get an anatomical view without having surgery. So I think MRIs are great. They should be used responsibly, and the problem is not MRIs, it's how clinicians are educated and trained, and we should try to fix that and not demonize MRIs, which kind of leads me to the next thing is, when I was immediately post-op, like I was in a ton of pain just from what was done locally. I woke up with a lot less nerve pain in my leg, and I was able to stand for much longer, but it felt like, like kind of like a Royal Rumble, the old school WWF, when like everybody on one team just took a chair and hit me in the back, which that's what it's supposed to do, right? Like I literally had my, muscles on my back pried apart to access the deeper structures. And I had parts of my bone shaved away and ligamentum flavum and connective tissue to free up that nerve. So like it should hurt. And again, it's like pain medications are bad, opiates are bad. Ironically enough, I was in so much pain when I got discharged that I had to get my dosage of pain medication elevated. And it turns out that in the government's infinite wisdom, because of this opioid epidemic, they have mandated that, this is according to my surgeon, that physicians in New York State are not allowed to prescribe opiates more than every 8 hours, even though more frequently than every 8 hours, even though what I found was I would have relief for about 4 or 5 hours, and then I'd be in excruciating pain. And so ideally, these opiates would be prescribed for every 4 or 5 hours and not every 8. So I ended up having to get put on like another anti-inflammatory, a non-opiate, in between the opiate doses, because I was like in so much pain that I couldn't sleep. And we talk about things like bed mobility and stuff like that, which in outpatient PT, you don't think much about it. But when you're in excruciating pain from a surgery and like you can't get out of bed because you're in so much pain, you appreciate pain medication. So just like with MRIs, like opiates have a place in acute pain. Like people who have chronic pain probably shouldn't be popping opiates like M&Ms when there's no real like trauma there. But even like when I was in the military, did search and rescue, like we gave people fentanyl, we gave people ketamine that got their blown up or shot. And it's like pain management is one of the most humane things that you can do as a healthcare provider. So to take away a tool just because some people might abuse that tool, I think it's debatable. Like what side you should err on. Do you err on the side of, well, like we should have people who are in legitimate pain remain in more pain because some people abuse it, or should we allow physicians to prescribe these drugs at their own discretion with the potential that some people might abuse them? Again, it's like who do you ideologically want to hold the other party hostage? It's more of a philosophical question, but I mean, pain management acutely is obviously like very, very important. And I'm very appreciative to have had that, because I can't imagine not having that after that surgery. It would have made, the first week post-op just like very, very, very rough. And then, the other kind of like takeaway and lesson learned from there is, luckily I can like kind of rehab myself, but just thinking about, post-op pain, I don't think we were ever of the school where like if someone's post-op that we should be cranking on a joint to get range of motion. And my post-op guidelines were no bending, lifting, or twisting, which I didn't need to be told that, because acute pain is a very good kind of reminder of what you shouldn't be doing. And even with pain medication on board, like I literally, like the last thing that I want to do is do a freaking deadlift or throw a medicine ball the first week after my surgery. Like I didn't need to be told that, but obviously I understand why I was told that. But in situations where like you might be told that, look, like with a knee post-op, try to get the range, early range of motion. I don't think that there is ever a place to crank on people's joints and put them in excruciating pain just so that you can get a better reading on a goniometer. I mean, if you look at what happens when people have invasive joint surgeries, whether it's like an ACL surgery, knee replacement, hip replacement, like when they're asleep, they have full range of motion. When they wake up and their nervous system sort of becomes alive, so to speak, and they can perceive pain, then they get all that inhibition. So it's not like that range of motion is not necessarily available to them. It's that it's inhibited because they're in so much pain. And so just to crank on somebody and put them in pain to temporarily get a higher goniometer reading, when we all know that if we work against the nervous system, that even if we get an acute change in range of motion, 5 minutes later, they're going to stiffen up again. So I'm not saying that we shouldn't go after early range of motion if it's indicated after a surgery, but like there's a way to work with the patient and do it in a way where you're not eliciting pain. Like I think it's inhumane at this point, especially after having gone through a surgery, to crank on a joint to get range of motion. If you're competent and you know what you're doing, you should be able to get range of motion without really, really hurting somebody. So I just want to make sure I touched on all of my kind of like bigger picture points, because I don't want to make it about like, who cares? I had surgery. A lot of people have it, but I think from like a clinical standpoint and like a, overall like healthcare standpoint, like these are kind of the things, who's going to be the case manager, not vilifying imaging. Even like, how do you know when to have surgery? For me, they always said like the patient knows. Like I knew when it was time, because I was at my limit. And when they told me that I was a candidate, it's like, how much, maybe I could tolerate taking cabs and Ubers to work for another year and not walk for more than 5 minutes or stand for more than 5 minutes. But like, if these surgeries are available, like, then I want to have it and resolve the problem definitively, especially when my prognosis was that I'd be able to return to doing whatever I wanted to do without restriction. And there wasn't going to be any structural compromise or instability in the facet joint. Like they were able to maintain the integrity of the facets with the frame anatomy. So again, it was kind of like a no-brainer at that point. You talked about the surgical disparity. How do you really know who to trust and what procedure to go with when people all come up with the same diagnosis, but they want to solve the problem surgically in a slightly different way? Pain meds, kind of same thing as MRI. Like they have a place. They shouldn't be abused, but it's the humane thing to do to control somebody's pain acutely. And then again, just not crushing people with trying to get range of motion after a surgery. And then kind of the last thing is that having a surgery is very inconvenient. Like especially if you have a surgery where now you've got to go to physical therapy three times a week or whatever. Like now in your busy life, you have to find a way to do something 3 times a week when most of us are like probably pretty saturated with what we're doing already. So, and that's where I think, if you're treating a patient, especially that's post-op, number one, it's probably, unless they've had a surgery before, like the worst moment of their life or the most pain that they've been in. So if they're in kind of a bad mood, like I think that should be somewhat expected, and there needs to be some compassion for that, and not like, well, what you need to elevate them versus you expecting them to elevate you, because again, they went through a traumatic experience. It's probably the worst thing that's happened to them medically. And they also have to see somebody 3 days a week. They probably didn't want to have to see. Like, yes, some people like their physical therapist and they might enjoy the experience, but I think most people would rather not have to do it. So just appreciating that, like, this is probably the last thing most people would have to be doing. And we've kind of talked about this sort of, as much as we can, making it about them. And even though they're not going to be at their best, and trying to work around their constraints versus being dogmatic and saying like, here's what you have to do, because, they don't want to be here. And like, I don't want to have to like rehab my back after a surgery and do, very like remedial things to get myself back to where I was, but I'll do it because I have to out of necessity. So that's kind of it. I mean, I don't know if there's more that.
No, that was awesome, Doug. That was a great explanation. I think, everybody has their own experience and of going in after an injury, needing a surgery and all that kind of stuff. So I think it's kind of interesting to hear like the length of the process from somebody who was educated, medically. And let's be honest, like most of the people we work with that have surgeries don't have the same kind of medical education that we do. So I think there's so much value, like you talked about, in doing the multiple consults with 3 different surgeons like you did, and then finding the one that made you feel the most comfortable. Because whether you're going in for a surgery or you're coming to us just for physical therapy in general, it's like, as a patient, you're so vulnerable, whether you're vulnerable physically or emotionally, or it doesn't matter, but like, you know, you're not necessarily like your normal self, quote unquote. So I think going to somebody that like takes the time to listen to you and takes the time to appreciate your story, even if like some of the information they give you like doesn't necessarily matter, it's not going to change what they do, it's not going to change the intervention, like, you know, all the history, because it seems like all the 3 surgeons that you mentioned all have the same goal in terms of letting the nerve breathe, right? And there's just different approaches to it. And like you said, probably all 3 of them would have worked to some degree. So assuming you would get the same outcome, the surgery itself doesn't matter, but you're going to choose the person to perform the surgery that you feel the best with. Like I said, who kind of makes you feel like a person, not just a patient, and not just like you're this spine and I'm going to operate on this spine and I don't really care about anything else that's going on. Because, you know, we see people who do need to get a surgery and it's like they come in and talk to us about it and they have no idea like kind of what the process of the surgery is, and they need to be educated on like what the surgery is actually kind of trying to do and the reason for getting it. And you know, I think like the person who did your surgery and all the different people that we have good relationships with, other medical providers that we send people to, we send them to them specifically because they do such a great job of, you know, not just from an intervention standpoint, they do a great job, but they do a great job of making people feel comfortable and feeling safe in their clinic.
Yeah, it's like, who would you want to send a family member to, you know?
Exactly.
And if the answer to that is, well, I wouldn't send my mother or my brother or my sister, whatever, then no matter how competent the person is, they probably should go somewhere else. There's plenty of competent people who also have, you know, it's kind of like a restaurant. Like, there's plenty of restaurants that have good food and bad service, but in a place like New York, especially where you've got plenty of restaurants that have great food and great service, like, why not have both, you know? And when you're going to make yourself that vulnerable, then the human element and the interactive piece is so important. And one thing I wanted to touch on too that I forgot to mention is, you know, people often, especially now, like it's very easy to get kind of self-righteous about, well, like certain kind of treatments that don't work or don't have evidence behind them. And until you've been in like really, really like just a difficult situation and been very vulnerable and been in a lot of pain, not that like I ever had any desire to get things that might be considered to be like non-evidence based or like snake oil, whatever, but I can totally see why someone who's like in a ton of pain would do things that physical therapists and like traditional medical providers tend to demonize, because like you will literally do anything, especially to avoid surgery. And if it's like, all right, someone's going to rub some, you know, some kind of a thing on your body, or they're going to, you know, put magic beads on you. Like, yeah, I don't think that stuff works, and I wouldn't do it for myself. But I would never like make fun of a patient that did that, because I understand, especially having gone through this, like why they would do it. And chances are most people who do that stuff have tried like physical therapy, they've tried traditional medical care. And in many cases, they're seeking the crazy stuff because traditional medical care has failed them. Sometimes it's just not, sometimes you just can't fix everything. But sometimes it's because, you know, they went to physical therapy and the physical therapist spent 5 minutes with them. They went to a mill, or, you know, they went to an orthopedist who spent 2 minutes and was kind of like, hey, here's some ibuprofen and be on your way. So I totally get why people would do that. And I would, not that I before would like make fun of somebody that would do that, but it's like, I totally get why someone would seek some of these treatments. And then the only other thing was like, you know, people always want to know like, well, why did this happen? What's the root cause? Like, there's seldom a root cause. I mean, for me, you know, if I didn't have the congenital thing with a narrow spinal canal, I probably wouldn't be in this situation. But if I didn't have the athletic history that I had, the training history, and then, you know, like the military occupational history, then I probably wouldn't have had it either. Because like my father had the same thing, but didn't put his body through as much. So there's seldom kind of one causative factor. And it's, at the end of the day, it's kind of like, who cares? Like, once you've identified the problem, you just have to fix it. And you can what if it to death. Like, what if I didn't do this, and what if I didn't do that? But, you know, you get to a point where when it's time, you know, and once you've arrived there, it's very clear, like when you quote unquote need the surgery, because you're just like, all right, like how much more do I want to live the way that I'm living? And going back to like some of the, you know, surgery is a modern miracle, MRIs are a modern miracle. Like I can only imagine if this surgery wasn't available, I'm 40 years old. Like granted, 500 years ago, I probably would have been dead by now because I would have gotten killed by a wild animal or some kind of a disease that we didn't have a vaccine for. But like, you know, if this procedure wasn't available, now I'm 40 years old. I've got a 6-week-old kid. Like, you know, that nerve is not going to free itself up. So then what? Like, so not that I didn't have a ton of respect for the other people that we collaborate with clinically before, but you know, again, I think it's popular in physio to kind of demonize surgeons because it's like, oh, they do too many procedures that don't need to be done. But you know, again, surgeons, every time somebody goes under anesthesia and every time a surgeon cuts somebody, like there's a risk that somebody can be killed or permanently disabled. Like they have a ton of skin in the game and a ton of risk that they assume every time they work. So it's very easy to have a job where like the most dangerous thing that we can do is maybe have somebody hurt themselves doing a trap bar deadlift. Like, let's just be careful. I'm not saying that surgeons should be beyond scrutiny, but you know, if your experience with surgeons is that they're like tend to overprescribe surgery or they're not careful, then that's, you know, like your fault as a provider for not having the right network, right? So then, you know, then find quote unquote good surgeons that you can refer your patients to, because like of all the surgeons that we collaborate with in our network, I've never felt like, oh, like, I'm really worried that this person's just gonna, you know, prescribe surgery when it's not needed. You know, I think there's a reason why we work with the people that we do, because we think that they are ethical and they are careful. So again, I'm very appreciative for surgery and that these things are available, because I don't know what the alternative for me at this point in my life would be without it. Like, I don't think I could rehab myself out of it at this point. There's a mechanical problem, and the only way to fix that is to create, you know, more room for that nerve to breathe, so to speak.
Yeah, definitely just touch on too. I had a conversation with a patient yesterday, and he had spoken to 3 different hand surgeons, and he ultimately chose the one that he felt most comfortable with personally. And not that we expect to be in, you know, personal contact and like calling and texting doctors, but the doctor had offered his cell phone number to the patient, which I assume he's doing with most patients, if not all. And like that, even that goes a long way where like, yeah, you might never actually need to contact your physician, and like you really shouldn't have to, your surgeon, like after you have a surgery, but like just knowing that this person is extending themselves a little bit more than the others, like sort of goes a long way. And I mean, I know there's a lot of patients that will have come in and they feel like it's different because we just listen to them. And that's something like as a therapist is such a big thing that like, that's a luxury of ours because of our model too. Like, you know, if we were working in a clinic where we had to see 4 patients an hour, like you can't do that stuff as much. Yeah. So no matter how good of a therapist you are, like you're limited by your model. And then it could be the same way for any strength coaches that are listening too. If you're in a model where you're seeing 12 athletes at a time, like you can't get to know them as well, and you can't sort of figure out what makes them tick, or, you know, what are those quote unquote soft skills that each athlete might need to, you know, motivate them or make them reach whatever their specific goals are. So that's just something I think is super important. And then I wanted to just go back and touch on, you had brought up just like timing and how you would know, you know, like you'll know when the time is right. And I think a lot of it just goes back to like what you said. You don't want to just be able to walk down the block and back and like that's all you want to be able to do, because it's like, oh well, you're like 38, like you don't need to do stuff. You know, and just another patient of mine had scheduled a knee replacement surgery, and he's, you know, somewhere around 50 years old, 55 years old, and it again goes back to like his goals are different than potentially other people his age with the same knee issues, because he's a baseball coach. He's very active. He does private lessons one-on-one. He has multiple age level teams that he's working with. So he's got a very active life, you know, potentially probably more than most people his age. So for his goals, like if he doesn't have his surgery, you know, sooner than later, and he's gone through conservative stuff for 2-3 years or so at this point with injections and everything, if he doesn't get that surgery now and they just sort of push it back because it's like, well, you might have to do it again because the surgery has like an expiration, you know, having a knee replacement, you might have to have a revision or whatever. If he doesn't do the surgery now, like he probably won't be able to coach now, as opposed to like if you wait and push it back, like you'll be suffering now. But yeah, maybe when you're 80, you'll be able to walk a little bit more. It's like, well, you know, when you get to those later ages, like you don't need to do the things like this guy's making a living off of coaching. I would think most, again, it's like ageism potentially, but like most 80-year-olds aren't coaching, you know, multiple level age group baseball players and doing the things that he's doing. So I think that's huge, and like, and pairing your surgery timing with your goals. And you don't want to just be able to walk, like you want to be able to get back to the martial arts stuff you're doing, and kiteboarding and skiing and doing all the badass stuff that you're used to doing. So I think
what's funny about that though
important.
is that like the point at which I couldn't walk, you know, not when it got really bad, but like there was a point where I could barely walk more than 2 blocks, but I was like, I could sprint. I did a workout on the Versa Climber where like I would go like 6 seconds as hard as I could, do 5 swings with the 50 kilogram kettlebell. I would do that I did that on the minute for 30 minutes at a time when I couldn't walk more than 2 blocks. So like, it was weird because I probably, if I had the time, like could have kiteboarded too. When I was flipped the switch and I was like really busy and doing stuff, I could totally fool people and be very, very functional. And I even like 2 days or 3 days before the surgery, I actually played tennis. Like again, cooperative hitting, I wouldn't have been able to like play a match against a great player. But if you watch me play and you didn't know what I can normally do, you'd be like, this guy looks totally fine. So people can fool you, but when there's no negotiating, like when you can't walk, then, or you can't stand up for very long, then that's when it's time. And then to your point about people following through, like my surgeon called me 3 or 4 times a day the first couple of days post-op to check in. So I didn't expect that, but it was like very, very comforting that he did. And then, you know, the surgeons that like I tend to refer to, I've heard from their patients that they will receive texts from the surgeon, like, you know, the day after the surgery or the day of the surgery to make sure they're feeling okay. So
yeah, that might even be built in. That might even be built into like their front office staff actually sending those messages from a text message. Like it might be a number that's not even the actual doctor's number, but like if it seems like it is, and the patient's perceiving that as like, oh, I'm being cared for, like that's a huge benefit. And that's something that we try and do with like, we're going to email you back and forth, and we're going to be here. If you have any questions, feel free to email us. We can hop on a call or Zoom to sort of fit you in between your appointments if you're not coming for another month or whatever. So yeah, that's awesome that they would do that.
And like, even, you know, I mean, I had this thought where, you know, what if the surgery goes wrong? Because I had situations in my family where like my father had a medical procedure that went wrong and it ended up basically permanently putting him on a pacemaker. And like, that's a case where like, if you're going to sue somebody, that's like a legitimate case to do it. He didn't do it because he's kind of like, what's the point? Like, I'm going to ruin this guy's life. Like there's an inherent risk in medicine. And like, as all indications are that my surgery went really well, but I had a thought like, well, what if the surgery didn't go well and I woke up and like, now I'm worse than I was before? Like, I wouldn't even have the thought to take any legal action against my surgeon because he was so thorough, so kind, so compassionate. It's like, and this guy's done thousands of surgeries. If you read his Google reviews, like the only bad reviews he has are from people who didn't actually have surgery from him. And maybe like, you know, you always have someone where they misinterpret what you say, and like no matter who they see, they woke up on the wrong side of the bed. But like pretty much unanimously, like anyone who's had surgery from him, it's like 5-star review, totally raving in terms of like his clinical competence and his bedside manner. So that's something too you always hear when it comes to like medical malpractice, is that people, the medical providers that are essentially liked are the ones that are least likely to be prosecuted legally. I'm not even bringing this up because at no point like would I want to suggest anything negative about my experience with the surgeon, but in the abstract, like if something bad were to have happened to me, it's like, all right, you know, why, like this guy was so good to me, he has a dangerous job. Like I would be fined financially regardless of whether I were to get money in a lawsuit. And if there was irreversible damage from the surgery, if that can't be undone by anybody, then what's the point? Like I would have a numb leg or my back would hurt the rest of my life regardless. So now like I'm going to make myself better by, you know, make myself feel better emotionally by like trying to ruin somebody else's life who had good intentions and by all indications is very, very competent and professional. Now, I'm not saying there aren't situations where legal action against a medical provider isn't warranted, and there isn't such thing as negligence. But again, like based on what this surgeon did prior to the surgery, like he had my like complete trust, and even knowing that there was a risk something could go wrong, like I would never think to do anything to try to like hurt him personally or professionally.
I think that just goes to your point before about like the value of interviewing multiple clinicians, all regardless whether they're surgeons or not surgeons, doesn't really matter. Just making sure you have somebody that you genuinely feel comfortable and you have trust with. Because if you don't trust the provider, you're going to be going in with kind of devil on one shoulder and being pessimistic when that's not really going to help you achieve a better outcome. Versus if you go in and you're working with somebody that you have faith in and that you trust, I think like your chance of a better outcome is going to be higher just because you have a better overall attitude about what's about to happen.
Yeah, and that's a huge part of the process. Is like if you don't believe like placebo, like if you don't believe that what you're going to be doing, what you're going to do is going to work, then like now you're more likely to have like a negative kind of attitude towards rehab, and like that's going to affect your recovery. So you can't separate these interactive effects from like the quote unquote actual treatment. So yeah, it's good medicine to be nice to people, and you could say that like, well, that's not really treat like who again. In the totality, who cares? It's all part of the big picture, and all this stuff matters.
Be a good person, right?
Yep.
Awesome. Yeah. So we'll wrap this one up. I know you have somebody coming in to see you right now, Doug. Thank you for all this background. I think it's huge that you talk about back surgeries. And I think people often think they just hear like the horror stories, and they don't hear the good experiences that people have, and they don't hear it from a provider. In their experience with their own surgery. So thank you for that. And then, we'll wrap up this episode now and take any questions from people. So thank you for listening, and we hope to see you next week.
Thanks, everybody.
I mean, I guess like from like the model that you guys have, and you were saying before how you have this luxury of seeing patients for that amount of time and getting to know them, especially like we see some of these patients for multiple times a week. We know a lot about their lives. Do you think that like especially like therapists in this kind of setting have more of like a moral obligation or like duty for kind of directing these patients, because they're coming to asking you like, should I get surgery, should I not? I've been talking to these surgeons, they told me this, and they're kind of relying on us to kind of tell them what if they should get surgery or not. Do you think that because we know more like subjective things than the surgeon may, we have more of like a moral obligation or responsibility to tell them? Have you guys ever felt that way for patients who are like coming in?
I think we do have a responsibility to like be fully transparent and honest with them about the information that we have access to and like the information that actually influences our decisions. Versus like what the surgeon does. Like, again, like you said, totally different context in terms of, in our setting, say we see somebody for 2 times a week for the hour sessions that we do, but they get to spend 15 minutes with their surgeon, and their surgeon's calling for surgery right away because, they see the imaging that, maybe based upon their imaging in their training would say that surgery is necessary. But in our mind, from a function and symptomatic standpoint, maybe they're not experiencing the limitations in function or the type of symptoms that would correlate with that type of MRI finding. We have to, I think, morally and like ethically present that to them. And then ultimately it is kind of up to the patient to make the decision themselves. And I always tell patients this, I'm like, I know the body better than you do. You know your body better than I do. So I can't tell you what you feel. I can't tell you what you're experiencing. I can't, make the call for you. And like Doug said, and we've had like the physiatrist that he mentioned who he had seen is the guy who I had first say this, that like patients know when they need surgery. So like I'd always recommend like don't go into a surgery like with kind of a half-assed view of it, like meaning like don't go into surgery being like, oh, I don't know if I really need it. It's like that's the last thing you should do is like get a surgery if you don't really think you need it. So just because a surgeon may say you need a surgery, like Doug did, get multiple opinions. And that's why like we kind of check each other and stuff. Like I'll ask Greg questions. I'm like, dude, can you check this dude's shoulder out? Like I think he needs get referred out because I think this could be going on. Like, I want to be double checked. That's why like a good surgeon, and we had a case, I have a case like that right now where like her surgeon is sending her to another surgeon to get a second opinion on it to make sure that she didn't miss anything. And I'm like, that's an awesome practitioner. That's an awesome doctor who's like really trying to, cross every T and dot every I before going to the really invasive route of actually getting a surgery. So again, like I think from what we do as therapists and based upon our model and the time that we have with people, like, yeah, we definitely are, I would say, morally obligated to try to like direct people in the right path. And whether that's referring to good people, and like we said before, the network we've created with the other people and practitioners that we collaborate with, like it's taken a long time to find the different doctors that we genuinely trust. And they're all ones that we can shoot a text about a patient about, and we can have a conversation about and actually be able to understand where shit is coming from. So surgery is not, some people take surgery lightly, where if you've had a bunch of surgeries, like, yeah, whatever, it's just another surgery. It's not a big deal. But you kind of always have to look at like what the flip side of the coin is. Like Doug was talking about there at the end, it's like, well, what if something bad happened? Like there's always a risk with surgery. And I think from the things that I've tried to do with clients when they come in and they're maybe looking at a surgery, whether it's scheduled or whether they like are probably going to need a surgery at some point in time, is trying to educate them on like what the process actually is about the surgery and what can they expect. Because oftentimes, like Doug had a great experience with this, where Doug was actually told like he spent an hour with the doctor and got a great rapport and trusted him and could ask questions and all that kind of stuff. But like I've had clients get in and they're like, yeah, the doctor, like I'm scheduled for surgery like in a week and a half. And it's like, oh, did they like, what they talk about? I was like, nothing. They just told me that they just like show me my MRI and show me what's wrong. And then they're going to do a procedure that's called this. And then I'm scheduled for the surgery. And it's like, okay, did they answer your questions? And it was like, usually like patients are so frazzled in that moment because they don't know that they are about like coming to grips with the like emotionally coming to grips with the fact that you're about to get a surgery can be scary. So it's like educating them on like, okay, after the surgery, here's what you're going to expect. You're going to be in a brace for 3 weeks, not putting any weight on it or whatever. Just kind of giving them an idea of like what's about to happen to them helps them emotionally calm down and not be so stressed out and anxious about what's going to happen. And I'd say the good surgeons, and not meaning like they did a good surgery, but like the good people surgeons are the ones who, whether it's the surgeons themselves or their team that they've created, educates the patients on what they can expect before and after and like during the whole process of it. That just makes the patient have a much better overall experience and I would say outcome.
Also depends on like how long I've known this person for too. Like if they're coming in day one and they're like, should I get this surgery in a month? I'm like, I don't friggin' know. Like I don't know what you've been able to do. I don't know what you want to be able to do. I don't know if we could do anything that changes how you feel in a month. So like that's an impossible question to answer because like Trevor said, they know themselves more than you know them. Most of these people that we're talking about are people that come in, we've done things conservatively that sometimes they help really well and they can give people relief for a really long time. Sometimes it's like, yeah, that doesn't really work. So you probably do need something else, like an injection or medicine or surgery. So that's a huge part of it too, is like how well we actually know the patient is definitely going to determine like how I view a surgery that they're being recommended to do.
How about like, how does like a patient's prognosis, like say a patient, they're not going to be motivated, but they need surgery, like say a total knee replacement, but they're not going to put in the work like afterwards getting the surgery, but they're in so much pain, like, oh, I need it. How do you deal with like a situation like that with like a patient where they're not going to have a good outcome, but they need the surgery? Would it be beneficial for them to even get it?
I think it depends on the surgery. So for an example, if you're saying a knee replacement, I think that's a relatively like easy rehab process where if it is somebody that might be more lazy or less motivated to be physically active, I think they should probably still get the surgery if it's gotten to that point, where even if you can get them to just like go up and down their stairs an extra few times a day, like they're going to benefit from that from like a rehab perspective, because those people are probably at the point where they're not really into physical activity as much. They're not as motivated. They're not going to do the things they need to do to get back to being in a good physical state. So I would think for specifically talking about surgeries, like a knee replacement, I think would still benefit somebody who might not necessarily be motivated to like come to PT and get a program and, do things on their own. Whereas like, like Tommy John surgery, I'm seeing these UCLs all the time. Like you can't get Tommy John surgery and then just like half-ass it and kind of just show up in a year and pitch. Like, so that would be a situation. It's like, no, like you're not a good candidate because of your motivation so I think that answers your question, but yeah, there's definitely some surgeries that I think would still be useful regardless if they even go to a physical therapist afterwards or not.
I think, and part of that too is like being realistic, being realistic with them and trying to get the patient to be realistic with themselves on like, what are they actually trying to get out of the surgery and what do they want to be able to do after the surgery? Like I've had people who, like they're fine being like 80%. And if that's fine for them, like, cool. Like, I think part of why we kind of have a different approach to things is like, we always want to get people to be able to maximize like what they can possibly do. But unfortunately, or fortunately, whatever way you want to look at it, like some people just don't care. Like if Doug was kind of talking about stuff, he didn't want to like go back and like actually play tennis really hard and like not in a cooperative kind of chilled out way. If he wanted to actually do just some of the higher level things he wants to be able to do, like he kind of needs the surgery. And then after the surgery, he's going to have to train smart and do all this stuff to be able to get where he needs to go. Cause like some people will say it's like, I want to be able to run a marathon after the surgery. And it's like, if I know you're somebody who won't put in the time it's going to take to be able to do that after the surgery, like I'm going to tell you that. Like I'm going to be very honest, because otherwise they're going to be disappointed. Like they have a level of expectation going in that's just unrealistic. So I think like they kind of defeat themselves by choosing that intervention if they don't know what the process is to get where they need to go. So I think education is always such a huge part of what we do, whether it's like education about physical therapy, like what the process is going to be with us when they're in our care, or whether what the process is like after the surgery to get to where they want to go eventually. Because I think there's some misinformation, or not even misinformation, maybe there's just assumptions that patients make sometimes that it's like the same thing of it's like, I don't want to lift weights and get bulky. It's like you're not going to touch a weight one day a week and like look like a bodybuilder, like just like completely unrealistic. But people genuinely think that sometimes. So they have to be educated that like, yeah, just because like you want to go and pick up hoops after your ACL surgery, if you're, a 40-year-old man, it's like, yeah, you're not, unless you put in the work, you're not going to be able to like actually just go back up and like pick up a basketball and like play 5-on-5 with your friends after work like you do. Like there's going to be some time involved that you need to spend to be able to do what you want to do. So I just think being realistic, getting them to be realistic with themselves, and then educating them on if they really want that, how do they get there is part of the thing too, in terms of like choosing a surgery or not.
Yeah, and I remember, Joe, when you were a student with us, there was a particular patient, which you probably could remember, where he had some disc issues in his back. He's had it for a decade, and he can get to a level consistently for a long time where he's able to do everything he wants to do, which is he wants to be able to, cycle in his house, like on a Peloton, something like that. He wants to be able to walk the dog for half an hour, go for walks with his wife, potentially do like some level of, like body weight type exercise stuff, like once or twice a week. Like it's very, very sort of simple stuff in our minds because we're so used to like working with an athlete after surgery who wants to get back to whatever. And like for that guy, yeah, he would probably need a surgery if he wanted to do more. But he's extremely happy. He's even said to me, like, I'm doing really well and I feel great. I'm able to walk for an hour, and like, that's awesome. And it just goes back to like what their goals are versus what we think their goals should be. So it's always something to keep in mind. And it's like almost like every visit when somebody comes in, I'm like thinking about like what is this person's goal? And that's going to change what I do with them versus somebody with a different goal, obviously. Thank you for listening to the Resilient Performance Podcast. We hope to see you next week.
As a thank you for listening, we'd like to offer a 10% discount on all products at resilientperformance.com. Please use promo code PODCAST at checkout. That's PODCAST. And I also encourage you to sign up for our mailing list to receive exclusive articles only available by signing up. Thanks for listening.